I'm delighted to welcome you to the last session in the organ transplant seminar for the winter quarter. But I do want to remind you that we have a fairly complete spring quarter coming up, and that there's one addition at the beginning of the spring quarter. Currently, the spring quarter starts on Wednesday, April 17, but in fact, we're going to start a week early on Wednesday, April 10. We have a visitor from Israel, Dr. Sperling, who's going to talk about organ transplantation in Israel, which has been a sort of a controversial area because some of the buying and selling of organs have worked through Israel. I don't know that Dr. Sperling is going to specifically address that, but I hope that that will be part of the conversation. So that's April 10, and it's not on the schedule. So we'll meet here at the usual time. Today I am, Ross, yeah, come on. Okay. Today I'm delighted to welcome Mark RUSO back to the University of Chicago. Mark prepared a paper, Organ Allocation and Lung Transplant, with David Meltzer and Robert Gibbons, and Mark will be delivering the paper. Mark is now a cardiovascular surgeon who specializes in complex and reoperative aortic valve surgery at the Newark Beth Israel Medical Center in New Jersey. Mark received his MD from Albert Einstein, a master's degree from Dartmouth, and completed his residency and fellowship at Columbia University. Mark RUSO is an experienced heart and lung transplant surgeon who's participated in more than 400 organ transplants. He's authored 130 published manuscripts and textbook chapters focused on improving healthcare quality and clinical outcomes for patients with cardiovascular disease. It's a delight to welcome Mark back, and I'm looking forward to this wonderful paper. Mark, thank you.
I'd like to thank you for the opportunity to present this work. I almost didn't make it. My flight actually got canceled, and I was able to jump on another airline. So, but it's beautiful day. It got canceled. Yeah, it wasn't because of weather. It was. It sounds like it was a plane that I didn't want to be on. But again, I'd like to thank everyone. So this is some work that I've done with David Meltzer and Robert Gibbons. I'm going to go through a variety of things related to the allocation of organs in lung transplantation, specifically focused on the issue of medical urgency and geography and how those impact the allocation of organs. So disclosures, I don't have any conflicts. Our research has been funded by the Thoracic Surgery Foundation for Research and Education, and also by a startup grant from this CTSA ITM core subsidy. And I'd also like to thank Quan Her, Liz Johnson, and Orly Merlot for their help in developing the manuscripts related to this work. So briefly, lung transplantation is a therapy for patients with end-stage lung disease. These are people with cystic fibrosis, IPF, sarcoidosis, pulmonary hypertension, and COPD. Lung transplantation has been shown to improve survival and quality of life in appropriately selected patients. However, there is an issue, which is true in basically all areas of transplantation, where there's a critical scarcity of organs available for transplantation. That is, demand is greater than supply. There's less than 2,000 lung transplants performed in the U.S. annually, and there's somewhere around 400 to 500 patients that die every year while waiting. I'm going to assert that given the critical scarcity of organs, the primary objective of organ allocation should be to provide maximal net benefit to society from the available organs. So how are organs allocated? First, organs are matched based on ABO blood type, size, height, and weight, whether the patient needs right, left, or bilateral transplantation, and then this issue of medical urgency and geography. So for a minute, I'm going to focus on what medical urgency means and how geography impacts organ matching and allocation. So first, medical urgency. Before May 2005, priority for lung transplantation was based on waiting time. That is, the longer the patients were on the waiting list, the higher their priority. As you can imagine, that might create a selection bias. Critically ill patients who are rapidly decompensating were unlikely to survive to transplant, and stable patients who are well enough to wait were the ones who actually got the organs. Again, you can imagine that that could create a number of issues in terms of how the organs are allocated. In 2005, the lung allocation score was implemented. So this was implemented for a few reasons. First, to reduce the number of deaths on the lung transplant waiting list, to increase transplant benefit for lung recipients, and to ensure an equitable and efficient allocation of organs to active transplant candidates based on medical urgency rather than on waiting time. So medical urgency, as defined by the LAS score, was developed based on a multivariate regression model, first to predict the risk of dying during the following year on the waiting list versus the likelihood of surviving during the following year after transplant. The risk of dying is weighted more heavily than the likelihood of or than survival. I'm not going to spend a lot of time on this, but it's something to keep in mind, potentially for a discussion later on. So the scores can range from 0 to 100. Rarely do patients have a score less than 30, but a score between 30 and 50, to put this in perspective for people who don't see lung transplant patients. A score of 30 to 50, waitlist survival can be measured in months to years. From 50 to 74, survival can be measured in weeks to months, and greater than 75, it's usually days to weeks. So what are the factors that impact LAS? So waiting list urgency parameters include age, oxygen requirements, body mass index, diabetes, 6-minute walk test, functional status, and then some measures of pulmonary function. Post-transplant survival is based on age, need for mechanical ventilation, functional status, what their diagnosis is, and again, some pulmonary functional status. It's worth pointing out also that the way the score was constructed, it can be changed over time based on what what the model that they used to develop the score predicts, but this was the initial score. Those were the important factors in the initial score. So now on to geography. Under the current system, all patients are prioritized by LAS, but before LAS score, organs are allocated first based on geography, regardless of LAS. The primary unit of organ allocation is the local geographic unit known as the donor service area. In the U.S. and Puerto Rico, there's 58 of these. This is what the map looks like. So initially, again, organs are offered to a subset of appropriately matched patients based on blood type and size within the donor's DSA, so within one of those 58 areas. Therefore, it's possible that a less ill candidate within the DSA could receive an organ over a more severely ill candidate outside of that DSA. And further, it's possible that you can imagine, based on those borders, which are somewhat arbitrary in how they're drawn, that a less ill candidate may actually be located further from the donor hospital than the more severe candidate, but it's determined based on, again, geography and borders. So if there's no appropriate candidates available in the local DSA, then the organ can be allocated to the next largest geographic unit, which is the region. There's 11 regions. This is what the regions look like. So I'm going to present a real-life scenario. A 27-year-old cystic fibrosis patient was hospitalized in the ICU while waiting for a transplant. His LAS score was 91. That gave him one of the highest LAS scores in the country, and again, that suggests that his survival is measured in days to weeks. An appropriately matched organ was available 20 miles away from where the patient was hospitalized, but it was outside of his DSA area. So this is what the waiting list looked like. The yellow line, that's our 27-year-old. He's number 5 for priority. If you look at the LAS here, this patient has a score of 91. Patients who are ranked higher in priority have scores of 40 and 42. Again, those are patients whose survival probably can be measured in months to years. These are patients of particular interest. Actually, the patient of 31. The reason I highlighted 2 and 3 is because 1 and 4, the patients, the organ was declined for reasons that I don't know. But if you expand the list further, you can see that the area in yellow, those are all patients with higher LAS scores than the 2 patients who are in the positions 2 and 3. So that's just on one page. There's actually, I think it turned out that there was 27 people who had a higher LAS score in the region than the patients, the local patients who were ranked 2 and 3. So what happened? So again, just to reiterate this, currently lungs are offered first to the subset of patients in the local DSA, and it only is offered out regionally if there's no acceptable candidate. And this So in this case, number 2 on the list was a 69-year-old, which creates, we could have an entire discussion about the ethics of transplanting 69-year-olds, but a 69-year-old local candidate with an LAS score of 40. Number 3 was a 71-year-old with a LAS score of 31. Number 5 was our 27-year-old regional candidate with an LAS of 91, located 20 miles away from the donor hospital, but outside of that specific DSA area. So given the critical illness of the 27-year-old regional candidate, a request was made for compassionate release of the organs. That is, the transplanting center for that candidate went to the other center and said, would you please not take this organ so that we can give it to our 27-year-old? That request was denied. The organ went to one of the local candidates. I don't know if it was the 69-year-old with an LAS of 40 or a 71-year-old with an LAS of 31. 3 days later, the 27-year-old candidate was placed on ECMO. 5 days later, he died. So there's a couple things that clearly I'm placing value on people's lives, saying that I don't think that I was unclear in my suggestion that the 27-year-old probably has greater benefit from the transplant than the 69 and 71-year-old with lower LAS scores, but maybe that's not true. So first, do patients with higher LAS scores receive a greater benefit from lung transplantation? So this is a study that we did with looking at the UNOS database, which is the national database for lung transplantation. The study population included all lung transplant candidates greater than 12 years old between May 2004, which is when LAS was implemented, in May 2005, I'm sorry, May 4th, 2005 through May 4th, 2009. There were 6,000 people approximately in that pool, and follow-up data was available through November. So we stratified the transplant candidates based on their LAS at the time of listing into 3 categories: LAS less than 50, 50 to 74, and greater than 75. So basically what we did was try to calculate the net benefit net survival benefit of transplantation by calculating what the actuarial survival for a patient was based on a given LAS score if they remained on the list versus what their anticipated survival was, or the anticipated graft survival if they were transplanted. So the waiting list outcomes include patients who are live on the waiting list, patients who are transplanted, dead on the waiting list, or lost to follow-up. So the actuarial wait list survival, candidates were followed from the date of listing to death, which was the outcome of interest, or if they were transplanted, they were censored, or lost to follow-up, they were censored. Post-transplant actuarial graft survival was calculated. Recipients were followed from the date of transplant to graft loss, which was the outcome of interest. If they were lost to follow-up, they were censored. It's worth noting that almost none of these patients are lost to follow-up, because if they're lost to follow-up, they're usually dead. So the net benefit by LAS. So if you look at the what we call the low priority stratum, which is LAS less than 50, you can see that the waiting list survival and post-transplant survival basically overlap. Suggests the way I would interpret this is the area between these two curves is the net benefit. Basically, there's no net benefit. And if you further stratify this by LAS ranges of 10 points, actually patients with LAS less than 40, the waiting list survival is superior to the post-transplant survival, suggesting patients actually have a negative net benefit. You can see in the intermediate term, or in the immediate priority stratum, LAS between 50 and 74, there's a pretty good distance between. This is the post-transplant survival curve. This is the waiting list survival. There's a pretty significant benefit here. Same thing with the high priority score. So what do we conclude from that? We conclude that recipients with LAS less than 50 receive little or no net benefit, survival benefit from transplantation. And it's, as I mentioned, if you further stratify those, patients with an LAS less than 40 may actually do worse with transplant than without. Recipients, and that's actually something to keep in mind when we get into who actually gets the organs. So recipients with LAS less than 50 appear to receive a net survival benefit from transplantation. So the next question is, who actually gets the organs? This is a breakdown of how the organs were allocated based on LAS. You can see that 60% of the patients who are transplanted have an LAS less than 40, and another 23% have an LAS between 40 and 50. So basically, more than 2/3 of the patients who are transplanted have an LAS less than 50, which, based on the survival curve, suggests that we may be getting marginal benefit. There's issues of quality of life, which we can talk about later. It might not be all about survival, but nevertheless, there's a significant minority of patients who get transplanted with an LAS greater than 50. So looking at this differently, LAS score less than 50, most of the patients with an LAS score less than 50 are receiving lungs locally, and most of the patients with LAS scores greater than 75 are receiving lungs regionally or nationally. So that means that the organs actually have to be offered out into a greater area for the higher priority patients to receive the organs. So another study that we did, basically using the same data set, we looked at the distribution of patients who are listed for transplant and the patients who are transplanted by LAS. And you do see, in fairness, that so this is all of the patients who are listed with an LAS less than 40. These are the ones who are actually transplanted. So low priority candidates, those are patients who have an LAS less than 40, and between 40 and 49 comprise the vast majority of both candidates, so people who are listed, about 88%, and recipients, almost 90%. So subsequently, we looked at what the natural history of survival on the waiting list is. So, and the reason that this is important is, okay, so most of the patients who are listed have lower scores, and most of the patients who are transplanted have lower scores, and that's probably not a problem if people with higher priority scores aren't dying on the waiting list. But we ask the question, essentially, is, were they dying? So again, same data set. So this is a curve looking at patients who are alive on the waiting list, percentage of patients alive on the waiting list over time. So the alternative is either that they died or they were transplanted. So these are patients still waiting. So if you look at most of the outcomes determined in the first 60 days, you see that very few of the patients with a score of greater than 90 are still on the waiting list even at 60 days, and almost none, I think, so patients who have a score greater than 40, less than 6%, that's not right. That's not right. That should say greater than 90. Less than 6% are still alive on the waiting list at 1 year. But of the patients who was actually transplanted, you see that, again, focusing on the 60-day mark, because that's where a lot of the curves are the steepest, you can see that actually we'll focus on 1 year. At 1 year, the highest number of patients transplanted was, again, patients in the lowest LAS group, so 40, basically less than 60, and the lowest was the higher priority candidate. So what we're really interested in, who's dying. You can see that at 60 days, 40% of the patients with an LAS greater than 90 were dead, and that it's a stepwise decrease as you go across LAS. So again, there's a fair number of patients who are dying with higher LAS scores while we're allocating organs to lower LAS patients. So based on this, we asked this final question that I'll present here is the local allocation of lung donors resulting in lower rates of transplantation among higher priority lung transplant candidates? So that is it actually the way the question that we're trying to get at, is it actually the way organs are allocated, or are there some other, and is it related to geography, or are there other factors that we aren't understanding here? So to determine that, and this is a very simple study in preparation for a more sophisticated analysis of this, was to determine the frequency with which when a patient with a blood group and size, when a blood group size match candidate with a higher LAS score in the same region existed, when organs were allocated to a local candidate. So that is, you have a donor, they match based on ABO blood type and size. Was that organ allocated to somebody with a lower LAS score locally when a more urgent patient existed regionally? So we used the UNOS data. We got special permission from UNOS to, we actually got daily LAS scores for each candidate.
Just to clarify, does this mean they would have gotten the organ if they'd been local?
Yes. Yes. So we got a special data feed from UNOS where they provided LAS score for each candidate every day. I'm sorry?
It would have been offered.
It would have been offered. That's fair.
Mean that this gap.
So what we were able to find was there was 5. So we looked at 2009 data. We limited the analysis to double lung patients, and that's because it becomes too complicated to look at right versus left versus double. So there was 580 double lung transplants that occurred in 2009. The data that UNOS provided us actually had 5 million observations, because again, it's LAS for each day. So it was the day and the LAS score that was basically the observation. It's not patients. So we defined an event as, again, when an appropriate ABO matched, height matched, double lung candidate existed in the same region as a donor but the organs were allocated to a local candidate with lower LAS. Is that more clearly stated? Because I know that I stumbled over it the first time. So the primary outcome measure was what we called an event, so any event. And the secondary outcome measures, basically we looked at the LAS point differential. So that is, what was the LAS score of the local candidate who actually received the organ versus the regional candidate who did not receive the organ. And then we looked at the number of transplants that were impacted, and most importantly, the number of people who subsequently died after they were bypassed for an organ. So delta LAS, again, is the differential between the local patient who was transplanted and the regional patient who was bypassed. So any difference, this occurred about 3,400 times. A difference of greater than 10, it occurred about 800 times. A difference of greater than 25, it occurred 250 times. And a difference of greater than 50 occurred 63 times. So that means for each transplant, so each one of those 580 transplants, there was an average of 6 regional patients who had a higher LAS score, so greater urgency, than the patient who was actually transplanted. There was about 1.5 with a 10-point differential. There was on average, half a patient for a 25-point differential, and about 1 in 10 transplants had a differential of greater than 50 points. So how many transplants did this impact? So any point differential, it was 480. So that equates to about 83% of all transplants. There was somebody who had higher urgency who was not transplanted. A differential of greater than 10 points, it was about 55% of the transplants. A 25-point differential was about a third of the transplants, and a greater than 50-point differential was about 8% of the transplants. So this is what I would view as the most important, even though it wasn't the primary measure. I think this is this is sort of the upshot. So how many of those patients subsequently went on to die? So any point differential, 15% of the patients went on to die. If there was greater than a 10-point differential, 27% of those patients went on to die. If there was without being transplanted. If there was a greater than a 25-point differential, then about 1/3 went on to die. And if there was greater than 50-point differential, about half of those patients subsequently died. And
well, presumably some of the people who wouldn't have gotten the lungs, if these people got the lungs, would have died too. So do you sort of take that into account somehow?
I don't for this, and there's 2 simplifying assumptions here, and Ed pointed out one of them, that irrespective of your question, one problem is we don't know why the patients weren't matched. So it's possible that those patients would not have been transplanted anyway. So these are sort of an overestimate. But I'll also so to answer your question, in terms of would someone have died subsequently? It's interesting if you look at, and I'm not going to present this data, but if you look at patients most of the patients who are transplanted had scores lower than certainly lower than 50 and even lower than 40. When I say most, I mean like 90%. And so then the question becomes, well, would those patients have progressed in their disease process and then subsequently died? And the answer appears to be no, that most patients' LAS score doesn't change significantly over time. Whatever they're listed at, that tends to be what it is. And that's not to say that's true for all patients. But I have data, which I don't have readily available, but that shows that most patients' score stays within about a 5-point range, so they stay within the stratum that they're in. Very few patients flip in and out. One other thing I will point out, though, is this there's 185 patients who I'm basically claiming died because they were bypassed. You could make a counter argument that that's actually an underestimate, because we're only talking about 580 double lung transplants. We're not talking about the other 1,500 single lungs. And there's also a question of people who get double lungs. There's clearly some diseases where the patients need double lungs, but there's other diseases where they may not, and we could get greater benefit if we split those lungs and gave them to 2 different recipients. All very complicated questions to address here. So in conclusion, my conclusion is that the current allocation system results in a high frequency of organs allocated to lower priority candidates, even when an appropriately matched higher priority candidate exists regionally. So based on the data I presented, I would summarize this by saying that most donor lungs are allocated to low priority candidates, that is, patients with an LAS score of less than 50. Low priority candidates appear to receive little or no net survival benefit. Whether they have an improvement in quality of life, I can't estimate based on the data available to me. But the third point is that high priority candidates continue to die at reasonably high rates on the waiting list while this is occurring. So what's the current state of affairs in transplantation? If you go back almost 15 years, the Institute of Medicine panel concluded that broader organ sharing or broader sharing of organs led to an overall increase in the rate at which the most severely ill patients were transplanted, and a concomitant decrease in excess transplantation of less severely ill patients without increasing pre-transplant mortality. So this is a group that David and Robert sat on. I think that they were the first two authors on this IOM paper. Their analysis focused on liver transplant, but the questions are the same. In liver transplant, the allocation is slightly different than in lungs. Going on to 2000, after this report was issued, the Department of Health and Human Services issued the infamous final rule, which was intended to assure that the allocation of scarce organs will be based on common medical criteria, not accidents of geography. In 2005, the OPTN, Lung Allocation Subcommittee, recommended changes to the lung allocation policies to minimize the effects of geography on waitlist outcome in an effort to reduce mortality. Despite the above, lung organ allocation remains a locally based system. So opposing points of view, following the announcement of the final rule, there was a bitter debate in the transplant community about what should happen. Concerns were expressed that implementation of the final rule would increase the cost of transplant, so that is, by distributing organs by a wider geography we would incur greater costs. Force the closure of small transplant centers, adversely affect access to transplantation for minorities and low-income patients, and discourage organ donation and result in fewer saved lives. Based on the IOM report, there's no evidence to support any of these things, and 15 years later there's really no evidence to support any of these things. And I would also argue that transplantation is so expensive that adding a few $1,000s for a flight to procure an organ, if the organ goes to somebody who gets a significant survival benefit versus somebody who gets minimal benefit, it probably pays for itself, although I can't prove that right now. So what future studies are we doing? So basically what we're interested in, and this is really the upshot of this, and unfortunately we don't have final data to present, but using the same analysis that was used for the IOM study, which was a mixed effects regression model, we wanted to test our central hypothesis that organ sharing over broader geography would result in better organ allocation, as measured by higher rates of allocation to higher priority patients, improves survival on the waiting list among lung candidates, and increased net benefit of lung transplantation. Based on this data, I'll just throw out a few questions which represent largely limitations of the data that I have. First, all of this is based on the fact that we are, how do we define priority, and that the LAS actually appropriately defines it, which I actually think it's a pretty, it's at least a step in the right direction. It's a pretty significant advance, actually, in my opinion. But what should be the guiding principle in organ allocation? One of the first things I said, that the guiding principle should be that we get maximal net benefit from a societal perspective from all the organs that are available. There's people who would argue that that is not necessary, that shouldn't necessarily be the guiding principle. Is survival the most appropriate outcome measure? So one of the things that I said repeatedly was that in the lower priority groups, that survival is not improved, but it may be the quality of life is improved. So if patients are on home oxygen and transplant allows them not to be on oxygen, or if they can't get out of a chair and now they can have some quality of life, even if it doesn't improve their survival, then those quality of life measures are important. Unfortunately, there are no good quality of life measures in this population, which is definitely a shortcoming for the field, and I think that's something that should be addressed. But should we be transplanting patients with LAS less than 50? If we assume that survival is the most important outcome, then maybe we shouldn't. But again, there's probably other markers that need to be assessed before we draw any firm conclusions about that. And finally, do we really have a shortage of lungs relative to needy candidates? Based on the data that, based on the studies that I've done, I could actually make a pretty strong argument. I think that it's not that we have a shortage, we're just transplanting the wrong people, and that's why high priority patients are dying. I won't present my solution, but I'll stop there.
Thanks for your talk. I'm actually a supporter of regional sharing of organs, but when I listen to you talk, I'm actually struck by, it seems like the solution for this is maybe geographic sharing of organs, but it may also be sort of more policing of the list, because it seems, if it's true that people who, once they're on the list, don't really have a change in their score, then some people are being listed too late, and other people are being listed probably too early, and I don't know if the geographic sharing would alleviate that, or if there could be some additional list management that might
Yeah,
help.
well, I mean, there's people who are certainly more expert in this topic, and if you want to weigh in at any point, then please do. But there's clearly access to care issues, and also the natural history of the disease isn't necessarily such that people are on a gradual decline where they, could be picked up at any point along the way. Patients may have a sudden decline and then plateau, or they may just have a sudden decline and never make it to the list, or they may have that gradual decline. And that's probably also a function of their disease process. I'm talking about these patients like they're all the same, and one of the limitations is that COPD is not the same as IPF, which is not the same as pulmonary hypertension. And the problem that we have is that we don't have enough patients in each one of those subgroups to make generalizations about that specific subgroup. So I'm, again, bunching them all together as if they're all the same, and they are clearly not.
The scores come up very differently. I'm sorry.
The scores may be comparable, but the disease states are not as Mark has stated, and the progression of the disease state in each individual disease is very, very different. IPF patients tending to progress more rapidly, but they all start at the same level. I don't have any contention with what you've said at all. It was my contention as part of the group that actually formed the LAS that we should be doing geography, and that was the third rail of discussion. And I think that the discussion today should be centered on not so much the regions as on concentric circles from the donor area.
If I went on that, I would actually. Two things about that. In fairness to the group, so everybody, if you just hear this for the first time, you think, well, this committee had the opportunity to fix this. These laws are governed by states, so there are governors who have said we are not going to allow our organs to go outside of our state boundaries until our citizens have the opportunity to have a shot at them, essentially. And so this is way beyond. I mean, this is a much larger issue, and this is an issue that Don Shalala attempted to address 15 years ago, and still remains a pretty significant point of contention. Because you raised the point, I would, and again, there's people who know more about this than I do, but my understanding of organ allocation in hearts is that patients are organs are first offered to their status 1A, 1B, and status 2. They're first offered locally, and then if there's no local status 1A, then it's offered to a 500-mile radius, and then if there's no 1A, then it's offered a 500-mile radius of status B, and so on. And so, again, the idea is concentric circles rather than boundaries. You could do the same thing in lung transplant. You could stratify patients by LAS. I keep by custom, I've been stratifying by groups of 25. So you could do the same thing. LAS greater than 50, you could go locally. I'm sorry, greater than 75, you could go locally, then a 500-mile radius, and so forth. Again, the problem becomes that there are state laws that prevent this from happening. It can't be concentric circles because people have actually initiated laws that would prevent that.
The only thing that I would add to your concerns is the cutoff at 50 for transplant, just because for discussion's sake, 40 makes more sense because 40 includes the 80% of the highest scores, or the 20% of the highest scores, rather. And so it's a skewed distribution. It's not an even or a Gaussian distribution from 0 to 100. It's very skewed in the 30 to 40 range.
And again, to make this point, because I don't want anyone to walk out of here and think that we're 80% of the people that we're transplanting aren't getting any benefit. Again, one of the problems here is that a patient with an LAS score of 40 who has pulmonary hypertension might be different than a patient with COPD who has an LAS score of 40, or a patient with IPF who has an LAS score of 40. But again, the numbers aren't large enough at this point to be able to make any conclusions based on those specific subgroups. So that piece of it, I don't want anyone to walk out of here thinking we only need to do 20% of the transplants that we're doing.
May not be suitable for a patient who would be at a higher score. So, that doesn't, your analysis does not include why the organ was turned down for that particular high score patient. Because if you transplant that organ on that high risk patient, probably the patient won't benefit because the patient may not survive because the organ is not really going to be able to support that patient. So that can be used better in a lower score patient because you will have a survival. So that is very important. One of the take-home messages is there is lung donors and there are lung donors, which are not equal in all terms. So you got to, there may be other things which are going not real, more kind of a judgmental in selecting the matching the donor for the recipient. The second thing I think you did already talk about, what is the geographical region? Is it the proximity or is it the borders? That's the issue, I think.
And again, we can move forward with the question. Let me see if I can pull up. Please keep asking questions. But again, to look at the geography, this is what the regions look like. So again, it's somewhat arbitrary of how the regions are drawn up. It's clearly not concentric.
Historically, this came about over a discussion in a bar late at night. About kidney transplantation in the late 1970s and early 80s, before UNOS existed.
But you're saying that even within these colors, there's not sharing. I mean, you're still
No, there is. So once the organ gets, there is in liver, yeah.
It's all, so it's local that is closest to the donor hospital within a service area. So all of the purple part of northern Illinois here would be one donor service area. This little thing up here is considered Wisconsin. That's Rockford. But that's by Wisconsin law,
And
which is another issue.
one of the things that's interesting, it's interesting that I chose this topic to explore because the center I'm at now, we're actually the second largest heart transplant program in the country. And the reason that is because there's essentially nobody else doing heart transplant in the state of New Jersey. So if an organ comes up, we have to turn it down before anybody else gets a shot at it. And so I trained at Columbia, which is in Manhattan and not far from where I work right now. And they've actually transferred patients to us because the waiting time is shorter. And so I frequently take the opportunity to make fun of them for that when we transplant the patient within a few days when their patient would have waited months. But it's not. But it's also an unfortunate, it's unfortunate that it's fortunate for us we get to benefit from that, but it's an unfortunate state of affairs. It's not good policy. Ross?
We really ought to have.
Why is New York its own OPO compared to every state?
Well, New York has separate, has two. There's New York City and everything else.
City and everything else.
Everything else, okay, I see. So Long Island is not
So it's basically partially based on that.
First of all, it's good to have you back. You want to stay? Second of all, your scenario that you presented at the beginning is pretty interesting. Not just because figuring out who's sick and who's not sick, but that another center wouldn't say yes to having a really sick kid transplanted.
You have no idea how interesting that is, and I don't want to say what the details of that scenario are, but it involves me, the center. It didn't happen. It happened somewhere else, but people. It's people who we know.
So I think who
knew each other.
Right, and the bad part about that is, so you can complain about the inefficiency of this system, but there was a very obvious scenario where somebody clearly would have benefited from being transplanted. Shouldn't even be an issue when you get contacted about it and they don't get transplanted. That's a bad problem.
Yeah, but those are the rules, and people will exploit the rules. Again, just to be clear, it's no one in this room, but it's people we know, and the people knew each other, and they should have been able to come to a reasonable resolution here. And it's particularly interesting because we could have a debate about whether people who are 70 years old should even be transplanted. The median survival post-transplant for patients in their 70s is less than 2.5 years. The 27-year-old cystic fibrosis patient, he probably has the best opportunity for long-term survival of any of our candidates. So there's a huge inequity in terms of what the potential benefit to that patient was, and what the I don't know what the outcome of that patient, although I could probably find out what the realized benefit from that specific organ was. It's a really interesting scenario, but it happens all the time.
Could you go back and talk a little bit more about the two notions that you had in one of the earlier slides? What does priority mean? It seems to me that that's related to the one that followed. What principle are we following?
Yeah.
So would you explain in general what that question,
what
priority means, and then what your own priorities
So
would be?
that's what's confusing about this. The way LAS is presented, we would say the guiding principle is LAS score, and that's how we allocate organs. But clearly, what trumps that is geography, which is why we keep going back to geography. So priority is determined again based on what you're into, and at any point, because you were on the committee that did this, and so you're much more expert in this than I am. But the LAS score was developed based on a multivariate regression analysis of the UNOS database to determine factors that were predictive of both survival on the waiting list in the absence of transplant and survival post-transplant. transplant. So in an attempt to determine who would get the greatest net benefit, that's what that score represents. Now, one of the issues here is that you would think, well, the sickest patients, you might think quickly the sickest patients are going to get the greatest benefit, but they might be so sick that they will have a poor outcome post-transplant, or in the absence of or with transplant. So that's one of the issues. And so, I'm sorry, I don't mean to. So one of the issues is LAS would suggest that the patients with a score of 90 have the highest benefit, but again, their survival in the absence of transplant is weighted twice what their expected post-transplant survival is. That might not be the right ratio, and so if you go back to my analysis where I showed you the areas between the two curves and suggested that, well, maybe it's, who is getting the greatest net benefit. By my analysis, it's actually patients with a LAS score of about 60 or 70 who get the greatest net benefit, because the patients with 80 and 90 are so severely ill that many of them just die immediately after transplant, and so they never achieve that benefit. Whereas the patients on the lower end of the spectrum, many of them would live for years in the absence of transplant.
So are you saying then that the priority means the number of survival years?
It's a predicted number of percentage of survival of the coming year is how the score
So
is
it's
coming year?
coming year, 1 year. That's how it's calculated. We looked at it at 1, 2, and 3 years of survival, and they were approximately the same, but more controllable at 1 year. So that's why we chose the number. It was statistically a stronger measure.
And I take it from the talk that you would have some qualms about that because the quality of life during that time is
well, the
not
problem is
considered.
that, each one of these steps. So first of all, we're talking about 1 year survival. Clearly, when you do a lung transplant, it's a $250,000 operation. We're hoping to get more than 1 year of survival out of the patients. There's a number of limitations. Is it absolute survival, or is it quality? Is there a quality of life or some other measure? There's so many. It's very difficult. And one of the problems with lung transplant is, and again, there's people who are more expert on me who can comment on this. I would say that the current era of lung transplant didn't occur until the early 2000s. So we don't have a lot of long-term follow-up. We don't have huge numbers of patients to look at. Liver transplant, kidneys, they have huge numbers of patients that they can look at. It's difficult in this area because there's a smaller number of organs that are available. If you're asking me what my opinion is, the guiding principle should be that the organs should be allocated based on the greatest net benefit to society. Do I know how to make that happen? I don't. I think it would be having long-term survival, having good data, looking at longer-term survival, say 3 or 5 year survival, and determining it based on, again, the net benefit of transplant versus not transplant. But again, that's much easier to say than it is to really hash out.
Thank you for such a intriguing and talk. But so the other side of the equation, you kind of just discussed this briefly, is the whole outcome after transplant. And we know that patients that have the higher LAS scores actually do poorly after transplant. And as a lung transplant, in the lung transplant community, we kind of wonder what is the best gauge of when we should say no to a patient who's too sick. And so your study argues a score between 50 to 70, but is that the question is that that would be another potential issue to address.
Well, and again, when you think about the complexities of that, because now we're assuming that LAS so we took a multivariate regression that's supposed to predict net benefit, and then we're going and trying to assess what the actual net benefit is within that. So the LAS has no, it has no innate meaning. It's a number. So we're sort of taking the net benefit of the net benefit in a sense, which makes no sense. No sense. But I think the real issue is, again, trying to come up with a regression model. First, so what's the outcome measure? What's the balance between survival in the absence of transplant and post-transplant survival? And then determining what the net benefit from that is. So there's issues with how the score is calculated, making sure that you have the appropriate data to even do that, which I'm not sure that we do, because again, we have to focus on 1 year because that's where we have enough patients to really be able to look at 1 year survival. If we looked at 3 year survival, then from we would basically eliminate 3 or 4 years of data, so that would give us 6,000 or 7,000 fewer patients in our sample. It's a complex issue. I don't think there's any, and that's why I say I think the LAS is a great step forward. It's clearly not perfect. To the credit of the people that developed it, it's sort of a living equation in that it should be reassessed over time and further improved. And that may mean that the balance between post-transplant and waiting list survival is adjusted. The factors in the model are changed over time as we get more predictive models. The model, for anyone who's a statistician here, the area under the curve for a model in predicting lung transplant survival at 1 year is probably about 0.65, and that's whether you can just use regression analysis, or you could use more complex computational systems, and it still comes out to about 0.65, which is not a great model, quite honestly. I'm sorry, let me say one other thing. And the other thing that we have to assume is that patients who aren't transplanted, that's them being censored does not bias us. I mean, patients may not be transplanted, may be delisted, and presumably those patients die, although I don't know that for sure. But we count them as censored rather than as a death on the waiting list, and that certainly could skew our estimates of waiting list survival.
So I realize you were trying to avoid this in some ways, but in your scenario, you posed the fascinating issue of this compassionate release, right? Which, from the description, it was intended to be that safety valve in some ways, right, on the scenarios that you are pointing to that are limiting transplants to occur, right? And it should work. So it seems to me there are two other factors in this. It's not just geography, right? You pointed to politics, state politics, which I think is a very real issue. And secondarily, it seems like there's a cultural issue in terms of relationships between transplant centers that's important. So my question with regard to that is, are there scenarios where the compassionate release actually works?
Oh, sure, absolutely.
Okay.
I can tell you scenarios where patients had, without going into the detail, positive cross matches, multiple positive cross matches, which means that there's very few organs that they could accept. One comes up, it was destined for somebody else, and a call goes, and people would release that organ. This is not representative. This should not be viewed. This is an absolutely extreme example that I happen to know of because I know the people involved. So then the question becomes, well, who should police this? In some level, it was the experts policing themselves, and even they couldn't come to a reasonable resolution as far as I'm concerned. I mean, these are people who are experienced transplant surgeons who know what the progression here is. There should have been no doubt what was a likely scenario here.
You're pointing to another research direction that complements in some ways what you're attempting to do here, which is to look at how it is that those transplant centers where compassionate release works judge values.
It's on a one-by-one basis. So you're at the whim of the there's one transplant team that has the upper hand, and you're at their whim.
But I imagine that those providers, when they're in communication in centers that work well with one another, right, that they have certain values and beliefs that they cling to as being important, in addition to the medical criteria that you're outlining, right? And that centers where that relationship doesn't exist, so that maybe there's a secondary avenue to be pursued here, which would complement what you're attempting to do with geography and mathematics.
Yeah, I mean, you could have a safety net where if there's clear inequity, but then someone has to decide on what that safety net is, which is probably just as complicated as solving the issue from the beginning. And again, these are people that knew each other. They knew, they were fully educated in what the likely progression was. They're as expert at this. I don't know who else you bump it up to, because these people had a relationship. They were 20 miles apart. They knew each other well. And these are the sorts of things that happen. I mean, if you want to talk about the ethics of transplantation and medical care in general, people have perverse incentives, and although maybe I shouldn't say this while I'm being recorded, not all physicians have their patient is not necessarily their number one priority. People get paid to do operations. They have certain incentives to achieve volume measures. They think that, I'm sure that I don't know this, but I'm sure that the conversation went, well, that guy has such a high score that something's going to come along for him and he'll be fine. Well, he wasn't. And then the issues become, the organ should be allocated locally, and there's some benefit to that. But again, there's arbitrary lines drawn there, and as far as how things are allocated, people would argue that there's a system in place and that's how the system works, and they were just following the rules. All things that I don't necessarily agree with, and I don't think that you do either. But somebody thought that was appropriate.
Well, I think that's another important thing is even people with low scores die on the waiting list. I think we shouldn't forget that.
Yeah. Although relatively infrequently. Patients with LAS scores of less than 40, less than 10% die in a year.
They do die.
They do die.
So I mean, it's important to realize that. So if somebody came in, it's hard for you to say, unless in a scenario like that.
And essentially what you're arguing is that you have to be the advocate for your patient. You are your patient's advocate, and that's what this person may claim that they were doing.
Yes, so I want to follow up on your last point that probably most of the speakers have talked a little bit about the perverse incentives, although none as directly as you have. And I think for those of us who aren't working in transplant, I'm wondering to the degree that you feel comfortable, if you can talk a little bit more about what you think the prime drivers are. You mentioned, for example, like small transplant centers, their survival, or states having an interest. What do you think really are the prime drivers? And as well as under the current system, which regions benefit, and which regions are the ones that are losing on the system?
Well, my institution benefits in a huge way, like I said, because there's another transplant center, but we do 8 transplants to every one that they do. Money is a huge incentive. A transplant pays about $250,000 to the institution, and that's sort of on average. So in metropolitan areas, it could be more than that. That's a lot of money. If you want to put that in perspective, a cabbage probably pays about $30,000. So you have to do 5, 6, 7 cabbages for every transplant you do. Money is a huge. I didn't say this, but someone recently said to me that I think this is an overstatement, but it's their view, that transplant is essentially a license to print money. The patients keep coming back. They need biopsies. They need immunosuppression management. Relative to all other things, it makes a lot of money, and it's a valued program. It's very prestigious. Centers want to say that. That's why there's a whole bunch of centers out there that do 4 and 5 transplants a year, because there's institutions want to say that they do transplant, and they have no intention of growing that volume, but they just want to say that they do transplant or transcatheter valves or whatever the high, robotic surgery, whatever sort of the high-end marketable things are. No one ever asks, well, how many? Most people don't ask how many do you do. They just know that they do it, and that's good enough. So so there's volume issues. You have to do a certain number to be CMS certified. I think it's 12 or 15 that you probably need to. 10. So I can tell you that this is a center that wasn't necessarily meeting their numbers every year, and they needed to do that. I mean, that one transplant difference could be the difference between their transplant program surviving and not surviving. So outcomes. I mean, it's a low LAS patient, even though they have advanced age. You would expect them to do reasonably well in the short term. There's a number of competing incentives, and they shouldn't be they can't be overlooked. Can't be factored in the context of this, but particularly in transplant, prestige and money have a lot of, I think, impact on the decisions that people make.
That all being said, I do think that the overall driving force is actually for patient care.
Yeah, I'm sorry.
No,
let me say now that I think that transplant physicians are maybe the most committed of all. I mean, it's there's a life. I mean, it's a life commitment. It's not just sort of a job that you show up for. So I don't want to say that, but there are these other issues.
When we were setting up the LAS, there was a lot of discussion about how we would destroy the collegiality of physicians and surgeons in lung transplantation, and we have in some ways. By allowing borders to get in the way. When there was a waiting time, everybody understood it, even if it was unfair, except to patients with COPD. But everybody understood it. There were no questions about it. There was collegiality. There was sharing for compassionate reasons. But when you start putting borders and rules and lines on it, then the mustering of forces to overcome those rules is much more difficult.
Just given that what you described, it strikes me this may be one of those cases where when you put the rules in place, people's psychology changes to, well, am I keeping the rules, rather than, am I doing the right thing? And I think about Chris Castle's essay knights, knaves, or pawns, talking about the way that the system approaches physicians changes their psychology about what they do. So if the system says, well, physicians are going to be perverse, so we got to put some rules around them to control them, well, then they start thinking in terms of just keeping the rules. And we see that with billing. You know, when in '98 or whenever it was, when Pennsylvania was fined $40 million for upbilling, they put all these rules in place, and now everybody upbills because the rules allow it to.
I was going to ask one of the questions that you kind of posed on your last slide. If it looks like, at least from a mortality standpoint, there's no benefits to transplanting in LAS below 40, has there been any medical research or discussion about whether there should be a cutoff at the lower end of when we should even offer a transplant?
I don't know if there.
I think we should get into the like fishing laws and the slot limit. 40 to 80, nothing above 80, nothing below 50.
Yeah.
Different issue. Different issue. There's a substantial difference in survival with scores above 80 than there are below 80 in the immediate going. Yes,
So
they get benefit.
So that's post-transplant survival. So,
Right.
so their patients' post-transplant survival is directly proportional to their LAS. That is or I guess I should say indirectly proportional. So the lower the LAS, the better their survival. Which, you know, if we transplanted, you know, if you or I were transplanted, we should do well. Would we get any benefit from that? Probably not. I'm sure we wouldn't, in fact. But the fact is, if you transplant a healthy person, they're going to do better. So again, that's why it goes back to the issue of net benefit. And that's really always the question. The problem in these situations is we know a lot more about what happens after we do something than if we choose not to do something. And so it's always difficult to assess what the true net benefit of anything is, because patients who get something are generally followed. It's easy to define their endpoint. Patients who don't, they sort of go away, and there's a number of confounding factors that may impact what happens to them after the fact.
I guess it just seems interesting that, to me, it looks like a low-hanging fruit example where you have this misallocation of a scarce resource for no net benefit. And you also, as you alluded to, have a perverse incentive for people to transplant, and 60 or to 80% of transplants are going to people who potentially don't need it from a mortality standpoint, and yet no one's addressed that problem. They're talking about.
Well, again,
radius
it's
and stuff.
multifactorial. So it's not that there's someone sitting above all this that has the magical power to change this. It's influenced by many things, and also, again, just to be clear, my endpoint of survival may not be the most important one. For COPD patients, I think we all know that they don't really get a great survival benefit, but their quality of life should be better. How do we measure their quality of life? That's a very difficult question to answer. So again, I don't want anyone to walk away saying that we're transplanting the wrong people, but I will agree with you that I think it's pretty clear that our system is imperfect. It could be fixed with some minor changes, but I have to tell you, I'm not optimistic that it will be changed anytime soon. As an aside, I got a call yesterday from somebody who was on the chairman of so STS is the main thoracic surgeon society. I got a call from the person who chairs the media and public relations subcommittee, which I'm actually on, to apologize because my paper, because one of these papers is in print this month, and it was up for sort of a press release and for them to promote, and they chose not to because they thought it was too negative, and they agreed that it was obvious that there's a problem in the allocation system, and they don't want people walking around thinking that the lung allocation system is perverse, which I totally understand and agree with. I thought it was actually very nice of him to call me and apologize, and unnecessary, but it is interesting when I give this talk to a group of lung transplant surgeons, people get up and there's the number of people who agree with the number of people who disagree is usually about 10 to 1. But I still don't think it's going to change.
Thank you, Mark, so much.